Alright guys, let's get busy talking about menstrual cycle disorders. If you haven't checked out our content on the menstrual cycle, I suggest you go watch that first because it will make this video make a lot more sense. We're going to be talking about primary amenorrhea today versus secondary amenorrhea. And primary amenorrhea is going to be when a person does not experience a menstrual cycle when they are 16 years old. So they've gotten all the way up to 16 years old and they still have not experienced menses. And then secondary amenorrhea is going to be absence of menses for greater than 3 months in a person who had a previously normal menstrual cycle, or it can be absence of menses for 6 months in a person who previously had an abnormal cycle. So I'm going to highlight these two for you guys. We will also be talking a little bit about types of dysmenorrhea here at the bottom, and we will get to that towards the end of the video. But I want to start out by talking about primary dysmenorrhea now that we kind of have some definitions of things. I'm going to be talking a lot about our diagram here, about the menstrual cycle, as well as our developmental biology. So you guys thought this diagram was gone, but it is back, and it's a really great diagram. It's going to help us with a lot of understanding. So getting into our menstrual cycle disorders of primary amenorrhea, I'm going to try and highlight the pathology in red because there are going to be specific time points or points in biochemical processes where a primary insult occurs, and then everything after that is kind of a cascade. So I will try and highlight that primary insult in red for you guys. So let's go ahead and talk about hypogonadotropic hypogonadism. And the classic example you're going to see on test day is going to be K.A.N syndrome. And how does a K.A.N syndrome patient present? It's usually going to be a patient who reports without having a menstrual period, and they're going to be 16 or 17 years old, and they may also say, and I also can't really smell. I've never had a sense of smell compared to my counterparts, and that's just been something that as I've always noticed in my life. And let's talk about this unique presentation and why it matters. So when it comes to hypogonadotropic hypogonadism, we are having an error somewhere in the axis of the hypothalamus and pituitary. In the case of K.A.N syndrome, these people have abnormal migration of GnRH producing neurons from the olfactory bulb to the preoptic nucleus. So in layman's terms, that just means they're not going to be able to produce GnRH. And we know that GnRH is going to be important for the production of luteinizing hormone and follicle stimulating hormone. If those are low, we are not going to get estrogen. And in these people, their ovaries are working just fine. There is no problem with the ovaries. The problem here is going to be in GnRH production. And this is going to be because we had that abnormal migration of those GnRH producing neurons. And a side effect of that is we also have abnormal migration of olfactory neurons. And so these patients are going to present with anosmia, which is lack of smell. That's going to be a classic buzzword on exam day. Let's move on now to talking about our hypergonadotropic hypogonadism. And our classic example here is going to be Turner's. And we're going to turn ourselves to our diagram here on embryology. So our error here in Turner's is here at the ovaries. And this is going to be important because we have streak ovaries in our Turner's individuals. And the streak ovaries are not capable of producing estrogen. And so we kind of get a failure of estrogen down here. It's not going to be produced. So if we look at our hormone cascade here, we're going to have increased levels of GnRH as well as increased levels of luteinizing hormone and follicle stimulating hormone. And this is because the hypothalamus and the pituitary are not receiving any negative feedback from estrogen. So they're like, why are we not getting estrogen? We need estrogen. Come on, ovaries make estrogen. But the estrogen is not going to come because the ovaries are streak ovaries. They cannot produce our estrogen. So our insult, our primary insult, is here at the level of the ovaries where we are not getting production of estrogen. So I'm going to write in here ovarian problem. Let's move on now to talk about some anatomical abnormalities that can cause primary amenorrhea. Let's talk about Mullerian agenesis first. So we know that Mullerian agenesis is going to be when the structures that come from our Mullerian ducts are not going to form. So if we look down here, it's going to be our oviduct, our uterus, and our upper vagina. And you know that we need a uterus in order to have a menses. And so if we don't have one, we can expect no menses. And so we're going to expect normal GnRH here because this is a uterine problem. This is not a hypothalamic problem. And then we're going to expect normal luteinizing hormone and normal follicle stimulating hormone because the ovaries are working fine. They are producing estrogen just fine. It is just the fact that we don't have a uterus. We don't have the anatomical structure to complete menses. So we're going to have normal estrogen levels as well. So I'm going to highlight here in red over this purple that I made. That is the fact that we just never formed the structure that we needed in order to carry out menses. The next thing that I want to talk about is our imperforate hymen. And a hymen is going to be a structure that is just inside the vaginal opening. And this is a picture that I drew of the vagina. You'll see we have our clitoris and our labia minora here. And then we're going to have this kind of peach area that I made these little lines over. And that's going to represent the hymen. And normally in youth, when kids are playing around, they're like horseback riding and doing gymnastics. And maybe they chose to put a tampon in at one point, or maybe they were sexually active at a young age. All these types of activities are actually going to put a break in this hymen. So we're going to get an opening here. And essentially with enough activity, this is going to continue to be made more and more patent, and we are going to be able to reach the deeper structures of the vagina. However, in some individuals, this does not happen. And so this membrane stays intact. And you can imagine that around age of menstruation, they're going to start having menstrual cycles. And the only way for that blood and that sloughing of endometrium is through the vagina. And so we're going to get a description of like a bluish, like a dark blue or a dark purple bulge here at the vagina. And this is because it is an accumulation of multiple menses that have all kind of coagulated and solidified and collected here at this hymen that is not open. And so what you can do for these patients is we can actually open up their hymen for them. So we can surgically slice that hymen open, and then all of these contents will come out. They will continue to have normal menses because everything else is perfectly working fine, and then they will no longer have this blue bulge. Additionally, these patients are going to present with a little bit of dysmenorrhea, but they don't know they're having a period, but every month they're having a period, so they're going to have things like menstrual cramps and things like that, and they're going to kind of describe those symptoms as coming on a monthly basis. If you were to ask follow-up questions, they're just not seeing any of the menses in the form of blood because it's being held behind this barrier of tissue. So I'm going to say here that our error is here, the imperforate hymen. We're going to expect to see that bulging blue membrane. That is our primary insult here. Let's move on now to talk about our enzymatic or receptor dysfunction causing primary amenorrhea. And classically, I like to think of complete androgen insensitivity syndrome. So in this condition, we are having a receptor for testosterone that is abnormally functioning. So let's say our receptor looks like this, kind of has this semicircle shape, but testosterone, let's say, has a triangular shape. These are not going to fit together, and so our body is not going to be able to sense testosterone, and therefore it is going to respond in a way that it feels like it needs testosterone, but nothing is going to be affected by testosterone. So in this case, we're going to get increases in luteinizing hormone because the anterior pituitary is not able to sense the testosterone, so it's going to be like, make more testosterone. So the body is going to go ahead and make more testosterone, but it's futile. The testosterone is not going to be able to exert any of its effects anywhere on the body. And what is going to happen when we have lack of testosterone's effects? Well, we know that testosterone turning into DHT is responsible for androgenergic agonism for external male genitalia, and so this is not going to happen. Additionally, we know that testosterone is important for maintenance of the mesonephric ducts, so these people are going to lack mesonephric duct structures that we know by the mnemonic SEED. Now, additionally, these patients are going to have normal testes. Now, additionally, these people are going to have failure of descent of the testes, so they can present with cryptorchidism, for example. And even more interestingly is these patients are going to experience peripheral conversion of testosterone to estrogen because we know that their luteinizing hormone is high. They are encouraging the testes to make a lot of testosterone, and that's going to be peripherally converted into estrogen, and it's going to lead to feminization effects because our androgens are not able to do any masculinization. So these patients are actually going to go on to grow things like breast tissue and feminine fat pads, etc., etc., because they have this testosterone converted into estrogen and they have no androgenergic effect to counter that estrogen. So in terms of a vignette for someone with androgen insensitivity syndrome, it's usually going to present as a patient who may be complaining of hermaphroditism. So they may have ambiguous genitalia because their genitalia are feminized from the estrogen that they got exposed to and the lack of androgens. And then they're going to have things like breast tissue, and they might have like sparse hair throughout their body despite going through puberty, and this this is because androgens are responsible for hair growth. And then if you were to do a karyotype on this person, you would see that they are an XY individual, but they may be struggling with whether they are a man or a woman in terms of gender expression, because a lot of their anatomy does not match traditional gender roles. And so you'll be able to figure out that this is androgen insensitivity syndrome by looking at this constellation of symptoms we just talked about. Our next enzymatic type dysfunction is going to be congenital adrenal hyperplasia, and this is going to present with variable levels of luteinizing hormone and GnRH and testosterone, etc. If you're not familiar with this diagram and haven't covered cholesterol and the synthesis of steroid hormones, let me brief you guys real quick. So essentially everything starts with cholesterol, and cholesterol is going to be our precursor for making things like aldosterone and cortisol and also androgens and estrogen. And essentially this cortisol undergoes a number of reactions via various enzymes to become these different things. And so you can imagine that if we have deficiencies in some of these enzymes, we are going to get shunting of various materials. So let's talk about 17 alpha hydroxylase deficiency. So let's say we got rid of this enzyme here. Essentially what's going to happen is we are not going to make as many androgens, and so we're going to have shunting of things in this direction. So we're going to expect things like high aldosterone. This might present as like a really high blood pressure in a young person, which we would not expect because they don't usually have high blood pressure. And then we're also going to have lack of the effects of our androgens and estrogens, and so that is one of the deficiencies. But let's talk about some other ones that you might see. We could see the opposite. We could have an absence of 21 or 11 beta hydroxylase, and this is going to shunt things in the other direction. So here we're going to expect high levels of androgens and all the changes that those are going to accompany. So we're going to expect precocious puberty, so like deep voice, really masculine features, high hair burden, things like that. And then we can also talk about aromatase deficiency, which is going to classically present as masculinization of a fetus as well as the mother at the same time. So I wanted you guys to be aware that this can also cause amenorrhea, because if we are unable to produce estrogen, then we are not going to be able to carry out a menstrual cycle. And so that's an important thing to have on your differential, and you're going to be able to look at this triangular diagram on test day and nail it, because it's really not that hard. It's just about knowing 3 important enzymes and kind of deciding which direction things are going to shunt in. Let's move on now to talking about secondary amenorrhea, which we discussed was absence of menses for 3 months in someone with a regular cycle previously, and absence of menses for 6 months in someone with an abnormal cycle previously. Let's start out by talking about uterine disorders, specifically uterine scarring post-Cutteridge, which we call Asherman syndrome. And if we zoom in here to my rudimentary drawing of a uterus, you will see that we have 3 layers. We have the functionalis, which is responsible for everything with menses. We have the basalis, which is going to be a population of cells responsible for regenerating our functionalis. And then we have our muscularis on the outside. And essentially what happens is if our patient requires a Cutteridge procedure, which involves a surgery where they go in and they kind of scrape away some of the functionalis. Reasons for this could be like you have products of conception in here, or a molar pregnancy, or something else that you would need removed from your uterus. They would go in and scrape around, but sometimes what can happen is that we can actually get scraping up in here in this basalis layer. And let's say that they did a lot of scraping in the basalis layer and they like really messed up. That's going to inhibit the regeneration of our functionalis layer, and essentially without our functionalis layer we cannot have a menstrual cycle. And so if I was to highlight the primary insult here, it's going to be this scarring post-Cutteridge, and we call this Asherman syndrome. Now let's talk about some ovarian disorders. We're talking about PCOS. So if you go back to our diagram on our menstrual cycle, we remember that at the moment of pop, we have ovulation and our egg pops out of the follicle. But in people with PCOS, this does not happen. And so that egg is going to remain trapped in this follicle. And we know that the follicle degenerating into the corpus luteum is going to be an important part of our menstrual cycle called the luteal phase. And this is going to be characterized by changes in the spiral arteries and secretion of specialized secretions to promote pregnancy. And then after that decrease in progesterone, that is going to trigger menstruation. However, this decrease in progesterone doesn't occur, and we may have experiencing increasing levels of estrogen because we never get that ovulation moment. And so these patients are going to be hormonally dysregulated, and they're going to be unable to carry out a normal menstrual cycle. Additionally, in order to recognize these patients on test day, you're going to be looking for things like obesity. and acanthosis nigricans, as well as evidence of diabetes and also acne. This is going to be a classic presentation, and this is due to the hormonal dysregulation in our patients with polycystic ovarian syndrome. We don't really know why these patients don't ovulate properly, but it is thought to be due to things like insulin resistance and obesity and metabolic syndrome and similar things to that area, but you don't need to necessarily know that for step one. You just need to be able to recognize the presentation of PCOS by this set of symptoms here that I'm circling and know why it will lead to amenorrhea. Now let's move on to talking about premature ovarian failure. So this is going to happen normally in menopause around age 50, 51, 52. Women are going to start running out of eggs, and we know that our eggs here are going to be super responsible for producing the estrogen and then the progesterone as the corpus luteum to carry out our menstrual cycle. So once we run out of eggs, we run out of the capacity to produce menses. Now sometimes people run out of eggs prematurely, and so you could be like age 25, age 30, and for some reason have like a low number of eggs, and once you run out of eggs, you can't have menstrual cycles anymore, and so these people are going to experience amenorrhea at a much earlier age than expected. Let's move on now to talk about some pituitary dysfunction. So talking about Sheehan syndrome first. Sheehan syndrome is going to be when we have a patient who has had a massive bout of hypovolemia. Usually this is going to be a patient who is postpartum, they experience postpartum hemorrhage, and we know that the pituitary is a watershed area, meaning that it is very sensitive to hypovolemia and blood loss. And what happens is essentially the pituitary experiences some acute blood loss. It's kind of starved for blood, and it's like, yo, I am done. I did not get enough blood, and I'm super tired now, and I'm not going to produce any luteinizing hormone or follicle stimulating hormone for you. You're not going to get any estrogen because I'm not producing the chemicals that you need for that, and I'm checked out. And so that is Sheehan syndrome. It's basically the pituitary giving up, and so you're going to expect low LH, low FSH. Now let's talk about something else called prolactinoma, and a prolactinoma is going to be a tumor of the anterior pituitary that produces lots and lots of prolactin. So normally the pituitary does produce prolactin, but when we have a tumor, it's like taking up all the real estate of the pituitary, and essentially the pituitary is only producing prolactin, and it's not going to produce any of the LH or FSH that we need because like those cells are getting pushed out by the prolactinoma. So you're going to get a patient who's presenting with amenorrhea, and then they also may complain of lactation discharge, so like discharge of milk from their breasts, because the prolactin is like, you need to make milk even though they haven't had a baby. And so the classic presentation is going to be like, I haven't been pregnant, I don't have a baby, but I have milk coming out of my breasts, and I also don't have a period. And you're going to be like, sounds like you got a prolactinoma. So that's a great way to nail that one on test day. Moving on to arguably the most high yield example of pituitary dysfunction is going to be functional hypothalamic amenorrhea. And that is a mouthful to say, but essentially what is happening here is we are going to have the pituitary giving up because it is under stress. And the classic vignette here is going to be a college athlete, so somewhere around age 23, 24, who works out a lot, is really busy, is really stressed with their studies, and essentially their body is under so much stress that the pituitary is giving up on everything related to reproduction. So we are expecting low levels of GnRH because the hypothalamus and the pituitary are like, we are not cut out to produce a baby right now. We are under so much stress. And so with no GnRH, we're going to have no FSH, no LH, therefore no estrogen, therefore no menstrual cycles. And so classically, you're going to see a female athlete triad, and this is going to be characterized by disordered eating. This is because they're so busy working out, they're so busy studying, they're not eating enough for the amount of exercise that they're doing. We're going to see amenorrhea, which we just talked about, and we're also going to see osteoporosis due to their nutritional deficiencies. And in terms of the hormones we would expect here, we would expect decreased leptin, because leptin is the hormone that is telling us that we're full, and these patients are never full. They're always going to be hungry, so their leptin is going to be low, and their cortisol is going to be high because they are stressed out. Their body is under a lot of stress. And this is going to result in the body saying, we are not ready for a baby, so decreased levels of GnRH, decreased LH, decreased FSH, leading to decreased estrogen. And I cannot emphasize enough how high yield this is. The female athlete triad will come up again and again on test day, so it's really important that you guys master the recognition of this vignette. I want to make a quick plug for pregnancy as a cause of secondary amenorrhea. We don't really consider pregnancy a pathology as a way of thinking about secondary amenorrhea, but indeed when patients are pregnant, they will not be menstruating, so I want you guys to have this in your differential of why a patient could have a stop in menses. Let's move on now to talking about dysmenorrhea, which is where you're indeed having a menstrual cycle, but the menstrual cycle is painful. And this can be classified as primary dysmenorrhea. This is probably how it's going to come up on exam most of the time. And this is what we call like classic period cramps. And this is going to be to increases in PGF2 alpha, which is a type of prostaglandin. And this prostaglandin is naturally produced in order to facilitate menses because it's going to cause vasoconstriction and uterine contractions. So when it's time to slough off that lining, we need to constrict those blood vessels so that the lining falls off, and then we need to initiate a cramping of the uterus, a contraction in order to push those contents out. And so we expect cramping as a normal part of the menstrual cycle. However, it can be uncomfortable, so we can manage this with NSAIDs and things like that for patients who are experiencing excessive discomfort. We can also have painful menses due to things like fibroids, which we will talk about more when we get into our specific uterine and vaginal pathologies, so stay tuned for that. We will talk about it more in a different video. I want to wrap up by talking about something now really cool called Mittelschmerz, which is actually German for middle pain, and this is going to be ovulatory pain related to the rupture of our follicular cyst. So we remember here in our moment up here in the diagram that we have ovulation occurring approximately at day 14. And when that happens, we're going to have a burst, and that burst can be kind of painful. It's going to cause some peritoneal inflammation. And additionally, at the same time, the fallopian tube is trying to scoop up that ovulated egg, and so it's contracting as well. And so kind of all that action in the adnexa can cause like lower quadrant pain. It's important that you don't mistake this for like an ectopic pregnancy or an appendicitis. So doing a proper workup and looking for like stable vital signs versus unstable vital signs and doing a beta HCG to see if this patient could be pregnant are all going to be important steps in differentiating Mittelschmerz from other more serious abdominal pathologies. So I just want to finish up highlighting here. It's due to contraction of the oviduct, and it's going to cause peritoneal inflammation. So let's wrap up now with our high yield review. I would say it's important to know your definitions of primary and secondary amenorrhea, and then knowing your primary insults. So we talked about primary insults, whether or not it was the hypothalamus or our ovaries like in Turner syndrome, or like lack of structures like our anatomical abnormalities, or perhaps it was an error with our enzymes like we talked about with our complete androgen insensitivity syndrome and congenital adrenal hyperplasia. And then we also talked about causes of secondary amenorrhea, which were actually similar. We can have anatomical things here, or we can have pituitary things, but these are going to be things that are acquired later on in life, and they're not necessarily going to be inborn like we see with the primary amenorrhea. If there were two stories to really know here on test day, I would know the female athlete triad as well as K.A.N syndrome. I think those just really pop out. So be on the lookout for a lack of smell with K.A.N syndrome, and then a stressed out college athlete for our female athlete triad. And then we wrapped up by talking about Mittelschmerz and ovulatory pain related to that follicle popping out. So I hope you guys enjoyed this video. I can't wait to see you guys in the next one.